Dr. Jin Ge. Today is actually my lucky day since I got to introduce another favorite person of mine at UCSF, Dr. G. So he attended medical school and business school at University of Pennsylvania. He then came to UCSF for residency, GI, and transplant hepatology fellowship. I'm not going to bore us all with all the awards and honors that Dr. G has received over the years because I think it would take another 15 minutes for this introduction. All I have to say that in my life, there are people that I'm always amazed how they manage their time and put in 100% effort in everything. And Gene is one of those people. He put in 100% effort in taking care of patients, 100% in educating residents and fellow, 100% in data science and AI research, and also 100% dedicated to his family. There's no one else I'd rather be with when I was on ILTU to handle an acute liver failure patient overnight. And that just say how much respect I have for Jin. We are so lucky to have Jin today talking about inpatient cirrhosis management and acute and chronic liver failure. Thank you, Jin.
Thank you, Mai, for a wonderful introduction. You're way too kind. So just for those of you who don't know me, I'm Jin. I'm one of the I'm an assistant professor now jointly appointed in the divisions of gastroenterology as well as the clinical informatics and digital transformation. And I'm here to talk to you guys about inpatient cirrhosis management and a bit about ACLF, but we're not going to be covering that portion that much. And I think I'll be returning later this year to talk about sort of indications for liver transplantation. How do we think about transplant patients? So to start off with, I think, this is just an acknowledgement that cirrhosis is quite a complicated sort of clinical condition to manage, and that there are a lot of different things involved in thinking about how do we care for patients with cirrhosis in the outpatient setting, but also in the inpatient setting. And I think to crux to the point is basically that there's significant variability in terms of etiologies, complications, prognoses. And something on the LTU that we think about all the time is basically, is the patient a candidate for liver transplant and whether they can undergo liver transplantation. It's a life-saving therapeutic, but it is also a scarce resource. And our patient population is quite sick. Patients with cirrhosis get hospitalized quite a bit. They end up being readmitted. 70% end up getting readmitted within 1 year. And the evidence is actually rapidly evolving on management. I remember when I started at the LTU, like 8, 9 years ago, that we were doing things very, very differently than how we're doing them now. And, we'll get into some of the changing evidence throughout the presentation. So, unfortunately, we don't have any first-year fellows here, so I'm going to have to call on the second and third-year fellows for these questions. But the first question that I want to pose to the group, 6 different choices. You have total bilirubin, creatinine, INR, or albumin, total bilirubin, creatinine, and INR, or add sodium to choice C. Choice D is birth, sex, total bilirubin, creatinine, and INR. And then choice E is albumin, birth, sex, sodium, bilirubin, creatinine, and INR. And then choice F, which is probably what we all do, is go to MD-Calc and just plug in the numbers. So who wants to volunteer for this question? And if nobody volunteers, I'm going to call out a second-year fellow.
Since I'm the one in charge of today's talk, I'm going to volunteer for the first one.
Sure.
The answer is F, but it's actually C.
So
It's C, but I do F.
Are you sure about that it's C?
I would think it might be E.
Yeah, Lakshmi, you're on LTU right now. So why is it E?
Well, because the newest MELD score is the MELD 3 score.
Yeah.
It incorporates all of these.
That's absolutely correct. So and I think this is worth repeating because this made it into my presentation last year due to the more recent updates in transplant allocation. But we see that the correct answer is E. This is MELD 3.0. It has been implemented since, I think, July of 2023. So it's been about 1 year now. And we often can get very confused because choice C, which is the MELD sodium, that was in effect from 2016 and 2023. And so that's the one that we probably underwent training with. And this is the one that we most often use. And we'll talk about why MELD 3.0 is important and why we have shifted towards MELD 3.0. I think it's worth talking a bit about the history of the MELD score and transplant allocation. So way back when in the early, I guess the late 20th century, um, the allocation for liver transplants were based on the Child-Pugh-Turcotte score, which is basically a set of laboratory studies, but as well as the variables of ascites and encephalopathy. And as folks who've worked with liver patients before, ascites and encephalopathy are very subjective things to grade. And so you can imagine that by using this for allocation for transplant, you created a lot of bias and disparities within the transplantation system. And so at the beginning of the 21st century, that was when the MELD score was actually first published. It was published in 2000, and it was a prediction model to estimate the probability of decompensation after TIPS, and that was extended to transplantation in 2001. And so MELD was officially implemented in 2002. And the MELD score, the advantages is that you have, at least the original MELD, you have three variables that were laboratory studies that were thought to be relatively objective, and that it kind of did away with the subjective grading of ascites and hepatic encephalopathy. Later on, Ray Kim over at Stanford, and he was at Mayo at this time, figured out that sodium or hyponatremia was associated with mortality in patients with cirrhosis. And so MELD sodium was proposed in 2003, but was not actually incorporated into the allocation system until 2016. And so that kind of tells you a bit about how quickly policy changes get made within liver transplant allocation, as well as how quickly or slowly that the system really moves. But I think, as we had more experience of the MELD system, the MELD sodium system, what we found was that the MELD actually contributed to persistent sex-based disparities within liver transplantation. And the reasons for this are actually multifactorial, but some of this was thought to be due to serum creatinine, which is underestimates renal function in actually, sorry, serum creatinine overestimates renal function in women, as in for a similar creatinine between men and women, women typically have actually lower renal function or GFR. And so, and height was also a big issue within allocation. And so there were a lot of papers that were published in the 2012 to 2020 era about how the allocation system did not work for certain populations, and that created a lot of disparities. And so what we did was that the community moved beyond the MELD sodium score to MELD 3.0. And I like equations because I work in data science, but the things that were incorporated into the MELD 3.0 now includes female sex, and this is the sex at birth, and basically patients will get an additional 1.33 points, and also serum albumin, which was also demonstrated to be associated with mortality. And so there are some bounds in terms of the variables. All of this is actually not super relevant for practice because we just end up going to a calculator and calculate it in. But I think it's important to harp on MELD 3.0 because the move we have moved to a new allocation system, and there are differences between a MELD sodium score and a MELD 3.0 score. And so when you're thinking about working somebody up for transplant, or you're thinking about like if they're going to get transplant soon, what their severity of disease is, remember to use the MELD 3.0 score. Don't use the MELD sodium score. Don't use the original MELD score unless there's special situations in which those scores may be applicable. But for all intents and purposes, please use the MELD 3.0. So let's talk about our case because this is a clinical talk. So we have a 54-year-old man with alcohol-associated cirrhosis who presents the emergency room with acute on chronic ascites and abdominal pain. And he stopped drinking alcohol about three months ago. He denies any encephalopathy, has never had a variceal bleed. He reports that his abdominal pain is preventing him from sleeping and walking, and he's becoming increasingly frail because of pain. And this is a very, very common situation with a patient who has ascites, who's not able to function because of these ascites, and is becoming frail. So how do you manage pain in a patient with decompensated cirrhosis? You got four choices: ibuprofen, hydrocodone acetaminophen, oxycodone acetaminophen. And I see Edgar making comments in the chat, so Edgar has to go. And Edgar, Mai, and Molly have all responded D. And the SFGH workroom has also responded D as well. By the way, who's in the SFGH workroom? Anyone? Nobody? Okay, we'll just continue. It's Diana, Wintu, and Jackie. Hi, Jackie. All right, so acetaminophen is the correct answer. And this is a slide that was borrowed from Jessica Rubin, who's one of my colleagues here in liver transplantation. And you know, the title pain management cirrhosis is a pain. I think this reflects the viewpoints of a lot of hepatologists about what is the best analgesia for our patient population. And there are a lot of like different patient disease, pharmacologic, and as well as clinician related factors that prevent us from or are barriers to managing pain effectively in our patient population. Notably, I want to highlight that and on the patient factors, there are a lot of our patients tend to have a lot of comorbidities, and there's a segment of the patient population that have substance use disorders. There are a lot of pharmacological issues, as in many of our medications are hepatically cleared, and there are no good biomarkers to measure the hepatic clearance. And then also from a clinician standpoint, there are no guidelines about how do we manage pain in patients with cirrhosis. And I think this is one of the things that Jessica is trying to work on in her research to figure out what is the best way to manage pain, as well as to publish guidelines about what are the medications that we can give for pain management. So, and this is another slide that was published by Jessica, where how is pain managed in cirrhosis, and we see that in the VA health system, most patients, a significant number of patients, actually end up getting opioids for pain management. And as everyone sort of knows, when patients are given opioids, especially patients with cirrhosis, they end up having altered mental status and ileus. And so this is not really the best medication to give our patient population. And I think what was interesting was that because of the longstanding association between acetaminophen and acute liver injury and failure, many patients with cirrhosis are not getting acetaminophen. And so this is a gap that we hope to correct with education. So what about acetaminophen? What about Tylenol? So yes, it is true that Tylenol causes drug-induced liver injury in the United States, but this is because when people take Tylenol above the recommended limits, and we're talking about over 4 grams per day in patients without liver disease, the upper limit of safety for acetaminophen in patients with liver disease, and this includes patients with cirrhosis, is actually about 2 grams per day. Now, why is it 2 grams versus 4 grams? And that's because in patients with liver disease, there is decreased metabolism of acetaminophen, and so therefore they actually get a more analgesia from the acetaminophen. And where people get into trouble is because of the combination opioid and APAP formulations, which may be high risk because people become habituated to the opioid component, and then they end up having escalated use. And if they end up taking Tylenol on top of it, then they get more Tylenol than they think they had. So NSAIDs are bad in patient cirrhosis. I think this is also generally true our preferences are probably true for our general GI colleagues as well. NSAIDs have a significant gastrointestinal bleeding risk, and as you guys know, gastric mucosal injury cause NSAID-induced ulcers in the stomach and in the small bowel. But for patients with cirrhosis, it's even more dangerous because it is associated with acute kidney injury, and it increases the risk. It's high risk in patients with ascites on diuretics. And so this is why, if a patient comes to me and they're on ibuprofen, I tell them to stop that and go to Tylenol. Opioids, I think this is a very straightforward reason why we don't like them. They have decreased metabolism and clearance in patients with impaired hepatic function. Patients with HE have an increased sensitivity to opioids. They decrease gut motility. They increase the risk of all-cause hospitalization, mortality, and in the post-transplant setting is actually associated with poor graft survival and increased hospitalizations. And if you don't believe me, just look at all of the different citations I have at the bottom. There's 1, 2, 3, 4, 5, 6 different citations I just listed here that highlights all of the downfalls and pitfalls, problems with opioids. So opioids, bad. All right, so we're continuing with our case. This is also a very common situation, happens a lot. Unfortunately, for the pain, he received IV Dilaudid in the emergency room and withdraws the painful stimuli. And so what are your next steps for management of severe HE? And we're defining this as GCS7. A, check ammonia and titrate lactulose based on serial ammonias. B, intubate, feeding tube, lactulose, rifaximin, and PEG. Adjust the dose based on mental stats. C, give flumazenil. And bonus points for the fellow who names why do we use flumazenil, under what circumstances. And D, intubate, use midazolam for sedation, administer PR lactulose. And Molly says B, Mai says B, and the SFGH workroom says B, and B is the correct answer. Who wants to say what's the purpose of flumazenil?
For benzo withdrawal, to precipitate benzo withdrawal.
Yeah, or to reverse sedation, over sedation from benzo. Yep, absolutely. And I've never had to give this during endoscopy, but this is one of the medications that you should know about in case if somebody gets oversedated. All right, yes, it is B. We intubate, we place a feeding tube, and we start giving lactulose, rifaximin, and go lightly. This is a slide about the management of encephalopathy. Usually, I think for this case scenario, we are down the severe HE route. We think about intubation, we think about putting in rifaximin, lactulose, and PEG. And if there's no improvement, then we think about head imaging as well as zinc. Usually, when you're managing hepatic encephalopathy, there's two concepts that you have to think about. One is basically, how do I manage the encephalopathy itself, which is actually pretty algorithmic. And the other one is actually thinking about what was the reason that caused the encephalopathy. And that takes a little bit more digging because our patients, if they're encephalopathic, they can't really give you a history. And the things you want to think about in that second situation is what precipitating encephalopathy is there an infection? And so they should get a full infectious workup. Is there GI bleed? So obviously get a CBC and sort of like monitor for signs of overbleeding. Is there AKI? What medications they get? Are they taking their medications? And I think that part of it is probably the most common cause of encephalopathy or these presentations is that they either took something, patients ended up taking a new medication that was prescribed to them that they unknowingly could cause encephalopathy, or they're not taking enough of the lactulose or rifaximin that they were already prescribed. I think this is one of the things that I still recommend fellows do when somebody comes in with severe encephalopathy. This was a trial that was done in 2014 on lactulose versus go likely for over HE. And I think the sort of like the conclusion is basically go lightly works extremely well when somebody has severe HE. And usually my recommendation to the fellows when you see the situation is that put in an NG tube and just start giving go lightly 1 liter per hour to basically clean out the bowel and try to wake them up. Now, this might be a apocalyptical or like a false story, but I like to tell this every single time, is that when this trial first came up, back in 2014, one of the attendings on the LTU who will go unnamed basically used so much go lightly that UCSF Medical Center ran out of go lightly for a couple of weeks. And so I don't think we're that aggressive about giving go lightly to everyone, but this is still one of the tools in the armamentarium that we use to try to wake people up when they come in so altered. What about rifaximin? So rifaximin does work, even though it's really expensive. It reduces hospitalization. Its use, despite having a high cost, is actually still cost effective because it reduces the episode of breakthrough hepatic encephalopathy. It decreases the need for HE-related hospitalization and the length of hospitalization. And the number of studies demonstrating the cost effectiveness, there are like 5 or 6 of them in the past 10 years or so. So what is the cost difference between rifaximin and lactulose? A monthly supply of rifaximin can be up to $600 per month, even more, whereas lactulose is dirt cheap. You can get a bottle of lactulose at Costco for, I think, like less than $12. So And so this is why a lot of people are not able to use rifaximin because it is expensive. And for many insurance plans, you do have to go through a pretty significant prior authorization process to get them. And this kind of speaks to the point that there is, for our patients who come in severe HE, that a lot of the issues around readmission are thought to be due to this coordination of care after the hospitalization. And so I think like as you think about managing these patients on the inpatient side and they're being prepared for discharge for outpatient follow-up, we should really make sure that the patients can access the medications for HE, so lactulose, rifaximin plus or minus zinc after hospital discharge. And patients and families should be really educated about HE management, that they really need to titrate the lactulose to get up to a certain point so that they're having really, 3 to 5 bowel movements. So, and this is an ongoing problem I think a lot of people are working on. How do we improve coordination of care in the outpatient setting after somebody that's hospitalized for HE? Ammonia levels, they have no impact on HE outcomes. So just remember this, burn this into your brain. When the medicine teams call you and say that, hey, I got an ammonia, it's 200, and the patient's like ANO times 3 in front of you, tell them, please don't get the ammonia for patients with chronic liver disease. They have no correlation, no association with HE outcomes. And in fact, what happens, and this was done by a couple of tutorials by Elliot Tapper, is that ammonia tends to lure people into a false sense of comfort about the presence of HE, as in somebody who comes in floridly encephalopathic and somebody gets an ammonia and it is negative, and they think, oh, this is not HE because the ammonia is negative. Or the alternative situation where somebody is not encephalopathic and then you get ammonia and it's super high, then somebody calls it HE even though it's not HE. HE is fundamentally a clinical diagnosis. Go examine the patient, test for ascites, test for a bit of cognition, and ammonia is not applicable unless, except for one situation which you may encounter every once in a while, and this is acute liver failure. In that situation, serial arterial ammonias, and arterial, I have to emphasize that, are associated with outcomes. And so that is the only situation, almost the only situation in which you should get ammonia to figure out if somebody with acute liver failure needs to go on dialysis or needs to, or is basically mental status is getting worse. But in the management of patient cirrhosis, ammonia has no part in that. All right. So we decided to give bowel prep for the patient to wake him up. He's now alert, oriented times 3, extubated. What about his worsening ascites? His abdomen remains distended, but he has no tenderness or pain upon palpation. He does not have a fever or leukocytosis. His INR is 3.5 and platelets of 30. It's also a Saturday. So what do you do to evaluate worsening ascites? A, diagnostic para, fluid sent for culture and blood culture bottles. B, diagnostic para with fluid sent for culture and sterile tube. C, no need for paracentesis because there are no symptoms, there's no leukocytosis, and it's also a Saturday. Or D, arrange for urgent tips. So I'm gonna call on the third-year fellow now, Rena, if Rena's there.
I'm here. Okay, I think we should do a fluid send for culture and blood culture bottles to rule out SBP.
Are you sure it's not C? It's a Saturday.
Yes, it's not C.
The
We
answer
still
is
gotta
no.
do it.
Depends on the site. That's a good answer, but no, that is not an excuse. And then D is absolutely not. So yes, the answer is A, diagnostic para with fluid sent for culture in blood culture bottles. This is a summary of the evaluation of the ascites. You get a diagnostic para, you look for a SAG, and basically what you're in portal hypertensive ascites, you're typically looking for high SAG, low protein ascites, and that's typically indicative of portal hypertension. If you're thinking about post-sinusoidal, which are things like congestive hepatopathy, then you're looking for high protein ascites, high SAG, high protein ascites. And then for peritoneal disease, such as like metastases or infections, you're typically looking for a low SAG ascites. So a question came over, anecdotally, do people use Miralax TID for mild HE if patients are having a lot of bloating in-house, or is it only studies in large volume go lightly? There's actually been studies about the non-inferiority of Miralax versus Lactulose. And so for my practice, if I have a patient that has bloating from Lactulose, I actually do switch them to Miralax, and I give the same titration sort of instructions. Start at TID. You can go as high as like Q2-hour Miralax if you need to, and try to get to 3 to 5 milligrams per day. And so, I think the most famous studies are the ones using large volume go lightly, but Miralax is a perfectly acceptable alternative to Lactulose if needed. So just to answer that question. Diagnostic paracentesis studies, just a quick overview. Things that you want to get, make sure you want to get a SAG, cell count with diff, culture, protein. And then for glucose cytology and amylase, this is really driven by clinical suspicion if you're looking for another cause of the ascites. Now, the question is that when should I do a paracentesis on a patient with worsening ascites? Do you want to do it within 4 hours of admission, within 1 day of admission? C is, I told you I'm not doing paracentesis because there are no symptoms, and it's also a Saturday. And then D is whenever IR can do the procedure. And since it's a Saturday, that's actually Monday. So, Christina, do you want to handle this one? If you're there.
Hi, yeah. I mean, I think earlier the better, but I think up to 1 day is okay.
Yeah, absolutely. Are you sure you don't want to do D whenever IR can be available for a procedure?
Probably not.
Yeah, that's also, I feel like that's also a site-dependent answer, but the correct answer is B, within 1 day of admission. And I think multiple studies have demonstrated this. I cited 4 down here, is basically early paracenteses is associated with better outcomes. So, and I think this is the part that we have to emphasize, and that up to approximately 30% of patients with SPP do lack typical signs and symptoms of fever, abdominal pain, or leukocytosis. The paracenteses within 12 to 24 hours admission is associated with shorter length of stay, less HE, less AKI, lower risk of death, and lower risk of admissions. And early paracenteses are less likely during a weekend admission. And so you think I'm making a lot of jokes about being a Saturday, but that's actually a big issue, that we don't get these paracenteses on Saturdays, even though there's really no excuse not to get them. And hospitalization at a non-transplant hospital. And what is also interesting is that linking back to the previous vignette about hepatic encephalopathy, the guidance from the AGA and the ASLD is that if you have a patient that comes in with HE or exacerbation of HE and they have ascites, you should tap that ascites and you should evaluate for SPP because it gets missed a lot. And that's a very common reason for somebody to present with severe HE. And so that's actually a quality metric from the ASLD now, is that any patient that comes with worsening encephalopathy or new onset ascites, they should get a paracentesis. And this is some of the research that will be coming out in the next couple of months from my work with the University of California-wide database. We, as a health system, and throughout the University of California, are actually not doing so well with these metrics, and we're only satisfying them about 30 to 35% of the time. So this kind of, I tell this data because this emphasizes why that we are not performing as well on the quality metrics, and that there's a lot of room for improvement. And then I think like there's a lot of interventions that we can implement to sort of like improve these rates. But going back to the clinical subject, if you look at the association between in-hospital mortality and the hours of paracentesis, and this was a very nice study that was published from Cornell back in 2019, you see that as the time to paracentesis increases, the hospital mortality kind of goes up. And this is almost like a logarithmic curve where it's hyperbolic and the risk increases in a geometric fashion. So how do we prevent so you get the para and you have somebody with SPP. How do we treat or prevent HRS in this patient population? And these were randomized controlled trials back in 1999 and also, again, replicated later on in the 2000s. Basically, you want to give albumin, 1.5 grams per kg on day 1, and then 1 gram per kg on day 3. And you also want to give at least a third-generation antibiotic, like a ceftriaxone, third-generation cephalosporin or broader antibiotic. And what we see in the previous studies is that the patients that get albumin and the patients that get the antibiotics, they have a much lower risk of renal impairment or HRS, AKI, and have a much lower risk of death both in hospital and at 3 months. So this is one of the things that in my research, we've demonstrated that the patients who get treated within the University of California Health, and this is all the centers across the UC system, that we're actually doing pretty well on the treatment of SBP with albumin and antibiotics. And so that's on the bright side, we may not be doing so well in getting the diagnostic para, but we are doing well after we diagnose SBP. All right, so we didn't correct the INR and platelets, and then we got diagnostic para to show no SBP. And 1 day later, his creatinine went from 1 to 2.0. He's on Lasix, 20 milligrams to 50 milligrams daily as an outpatient, and these medications were continued while as an inpatient. So how do we evaluate AKI in patients with cirrhosis, or how do we treat it? So A, we start midodrine octreotide. B, we increase the diuretics and diurese for the AKI. C, we hold the diuretics and give IV albumin. D, we hold the diuretics and give IV normal saline. E, we continue the diuretics and give IV albumin. So let's get somebody to respond. Stephanie, do you want to handle this one? If you're there.
I think Steph has a volvulus case that she's seeing right now.
Cool.
But I'll say to hold diuretics and do albumin. So I think
Yeah,
C is
that is absolutely correct. Are you sure you don't want to diurese for the AKI?
I won't, but maybe my cardiology spouse would. So we can work that behind.
I think the cardiologist would do that. So yes, we hold diuretics, we give IV albumin. And so this is the definition of AKI and cirrhosis. And believe it or not, there is a club called the International Ascites Club. A bunch of researchers, including Joe Colaro, who meet in fancy places in Europe to talk about ascites and AKI. And so the official definition for AKI in patient cirrhosis is basically an increase in serum creatinine above 0.3 within 48 hours, or an increase in serum creatinine by over 50% within the prior 7 days. And AKI in this situation is actually defined as highly associated with ICU transfers, longer hospitalizations, increased in-hospital and 90-day mortality. And so if you look at this, it's kind of interesting in that the amount of increase in serum creatinine is actually quite small for us to define somebody as having AKI. And so it makes me suspect that we are probably not being aggressive enough with albumin resuscitation, because a lot of our patients end up having increases in serum creatinine that's about 0.3, 0.4, and we typically don't do anything, or we do things for them, but we don't go to albumin. But I think this is one of the things to emphasize is that the research is telling us that even a little bit of a bump in the serum creatinine is actually can be significant, and this little bump can be associated with poor outcomes. And so the diagnosis of HRS, because I think this gets confusing for a lot of people, you have to have ascites, you have to have cirrhosis or portal hypertension. You have to have AKI as defined by the International Ascites Club. There's no response after 2 days of diuretic withdrawal and volume expansion with albumin. There's no shock, so there's no other cause of the creatinine. There's no nephrotoxins, and there's no signs of structural kidney injury. And so the urine protein must be less than 500 milligrams per day. There's no hematuria, and renal ultrasound should be normal. And what do we do in AKI cirrhosis? Well, we evaluate for precipitants. We hold the diuretics, and then if there is an increase in the creatinine, we give albumin for 2 days. If there's no improvement, then the HRS criteria is met, and then we treat for HRS. So The albumin typically is 1 gram per kilogram. It's a little bit different from the SPP regimen. And then once you do diagnose HRS through this diagnosis of exclusion, usually the treatment method is vasoconstriction of the systemic and splanchnic circulation to improve effective volume and renal perfusion. You give midodrine, you give octreotide. In some places, they actually do give Levophed on the floor, and that is also acceptable. And then you give an albumin dose about 40 to 50 grams per day. I think the new kid on the block is Terlipressin. This is a confirmed trial which demonstrated that Terlipressin does have a therapeutic effect in reversing HRS. It reverses HRS without need for renal replacement therapy. It reverses HRS in patients with sepsis or SIRS. But I think some of the things about this trial that were kind of interesting is that it was not associated with a reduction in death within 90 days. It's not associated with an increase in liver transplantation. And I think, going into this trial and thinking about the evidence, the reason why the outcomes were not very different was that there were quite a bit of number of adverse events in the Terlipressin group, notably that there were acute respiratory failure was higher, and respiratory failure overall was occurred at a higher rate. And this was thought to be due to systemic overload, increased systemic overload caused by the administration of a Terlipressin, as well as increased venous preload from giving too much albumin. And so the FDA ended up approving Terlipressin in September of 2022, and we do have it at UCSF. I'm not sure if we have it as the SFG or the SFVA. I'll let the doctors there to comment on that. But under this approval, if the patients with creatinine above 5 are unlikely to benefit, we should avoid use in patients with severe ACLF or volume overload. We should not use in patients with respiratory compromise, and we should not use in patients with bowel, coronary, or PAD ischemia. And so we have a work question from, if they do not have ascites, can they get HRS? Even though we had a patient earlier this month on service that was back and forth renal, she did not have ascites. Number 2 is that, do you stop oxygenate on pressors? Also, did you get an invite to the International Ascites Club? So answer number 1 is that based on the International Ascites Club definition, you have to have portal hypertension with ascites. If they don't have ascites, then technically they don't have HRS. So, and number 2, do you stop octreotide if they are on pressors? Yes, I would stop the octreotide if they're on pressors, because you're also causing splanchnic vasoconstriction with the pressors. Number 3, did I ever get an invite to the International Ascites Club? No, I have not. I'm not as cool as Joe Colaro, so I have not had a chance to go to a fancy conference in Europe. When should we be concerned about biochar nephropathy and confounding, whether a patient truly has HRS or not? That's a very interesting question, and I'm not sure there are any guidelines about sort of like when do we get concerned about biochar, like this clinical situation. I think usually this is recognized when somebody has a very high bilirubin, and we typically define this as above like 25 or 30, and they also have concurrent AKI. And so that's when you think about biochar nephropathy. Bilirubins, like this is a very kind of a fun question to ask on LT rounds, is how can you get a bilirubin that's above 30, and how can you get a bilirubin above 50? And typically, when you have a bilirubin above 30, it's because you have both hepatic failure and also renal failure. And that's when you have biochar nephropathy, because you're not actually excreting the bilirubin. You get it above 50 when somebody has both liver failure, renal failure, so they're not clearing the bilirubin, they're not excreting the bilirubin, and you have hemolysis on top. And so typically I like to think about biochar nephropathy when your bili gets above 20s, 30s, and then also that there is also AKI. All right. So I think a related question to all this talk about ascites and HRS, and this is one of the hypotheses about TIPS when it first came out, is should I get a TIPS? And the thought process back then in the early 2000s was that TIPS can help with AKI, HRS. And so which patients is or are candidates for TIPS? So A, 57-year-old refractory ascites, MELD 32, B, same patient, MELD 16. C, large varices on routine endoscopy, MELD 15. D, omitted variceal bleeding, Child's class B. E is a combination A and C. F is a combination B and D, or G, all of the above. And Edgar, since we're on the chat, please answer this question if you're still there. Or anyone, if you want to take a shot at this question.
I think we do B and D.
Yep, absolutely correct. B and D. And we sort of talked about this in the LTU teaching yesterday, but TIPS does have a survival benefit over serial paracenteses. There's a series of studies that were done in the late 2000s and early 2000 teens that basically show that patients with TIPS do much better versus those who undergo large volume paracenteses plus albumin. And what we found was that the association with mortality, the hazard ratio for TIPS is like 0.6. So pretty darn good effect. And you have to think about why is that? And it is very intuitive. The patients who get TIPS, they don't have to get a needle to their belly every couple of weeks. And obviously, any large volume paracenteses, they can go wrong. You have complications including bleeding, precipitating renal failure, or bowel perforation, which is a very, very rare complication. You're more likely to get bleeding from paracenteses than bowel issues. I think one of the reasons why we don't use TIPS that often is because we think that it increases hepatic encephalopathy. It's actually, there's a caveat to that. So the incidence of HE is somewhere between TIPS and paracenteses groups, but severe HE may be more common with TIPS. So for the people who do get HE, their symptoms may be worse. But I think the overall benefit is still in favor of TIPS because all of the other portal hypertensive complications improve with TIPS because you don't get as much GI bleeding because you're resolving the portal hypertension. You don't get as much SPP and you don't get as much HRS. So there's still a net benefit to putting in TIPS into somebody. Contraindications of TIPS. So there are a bunch of relative and absolute contraindications. The relative ones, pulmonary hypertension and HE. These are things that all could be overcome if it's technically feasible. And so this is times when you want to talk to an interventional radiologist as well as a cardiologist to figure out if my patient can undergo TIPS or not. The absolute contraindications, these are a bit more hard to negotiate or maneuver. And I think the things that you have to think about are, systemic infection, unrelieved biliary obstruction, and then also very severe congestive heart failure. And the fear here is that if you put a TIPS into somebody, you increase reload to the right ventricle and you overload their heart, and they either go into right ventricular failure or they go into left side heart failure. And the MELD cutoff, and if you guys notice, for the question, I specifically said MELD instead of MELD 3.0. We still use MELD for calculation of TIPS mortality or outcomes of TIPS. And we typically think about MELDs of about 15, 18 as the upper limit at which we would do a TIPS, or total bilirubin above 3. When should we consider TIPS for ascites? And this is a very fascinating question because historically, based on the guidelines, it was defined as quote-unquote refractory ascites. And nobody ever told us what refractory ascites means. Does that mean 10 paracenteses? Does that mean weekly paracenteses? Does that mean somebody who is not able to take diuretics because of AKI or hyponatremia? Nobody really defined it. And for the longest time, we didn't have any guidance until about 2020. And the recommendations now are basically after 3 large volume paras in a year, despite adequate diuresis. So if you think about the patients that we end up sending for TIPS, we're sending patients to TIPS who have like weekly or biweekly paracenteses, and that's definitely more than 3. And so the paradigm change now is basically that we should be much more aggressive about referring patients to TIPS, especially for refractory ascites. And once they hit about 3 paracenteses in 1 year, typically I start thinking about TIPS, get an echo, get cross-sectional imaging, and start making a move towards a TIPS placement. Now, the TIPS and variceal bleeding, this is the idea behind the preemptive TIPS, and Lupe Garcia et al. Has published a lot on this. And the greatest benefit from randomized control trials is basically patients with child C cirrhosis or certain classes of child B cirrhosis. Remember, this is a preemptive TIPS. So somebody has blood, you control the bleeding, and you're thinking about a TIPS to prevent rebleeding. This is not a salvage TIPS, which is, I think, the most common clinical scenario that we see is somebody comes in with variceal bleed, you try to get endoscopic control, you're not able to, they end up getting a Minnesota tube placed, and then you put in TIPS to sort of like as the destination therapy. And so this is the algorithm for TIPS in variceal bleeding. You basically scope them, see if they can be banded. If you do achieve hemostasis, then you think about if they're child's B or C, and you go for preemptive TIPS. And if you're not able to achieve hemostasis, then you think about the salvage TIPS in this situation. All right. So what is the best treatment option for a patient with refractory hepatic hydrothorax? We'll go through this quite quickly. Afshin, I know you didn't want to be called on, but sorry if you're here. Or anyone, what is the best treatment for HHT, hepatic hydrothorax?
If they're a candidate, then TIPS.
Yep. Jackie says transplant. That is true. It is transplant. But C is, in the absence of transplant, TIPS is probably the best choice. And, credit to Dr. Marr about the transplant comment. We actually don't have great treatments for hepatic hydrothorax. It's actually one of those complications of cirrhosis that's extremely difficult to manage. So if you look at the comparison for TIPS in so first of all, mortality rates for hepatic hydrothorax are extremely high. So you're looking at about 40% mortality in 1 year. Even if you TIPS them to try to control it, the mortality rates are still awful, even with a MELD underneath 15 or above 15. There are certain factors that are more strongly associated with mortality after TIPS placement for hydrothorax, notably a higher child puke score, higher MELD scores, higher creatinine, and lack of response after TIPS. The alternative is a plural catheter for hydrothorax. We see this situation quite a bit where a catheter gets placed for management. The problem with this is the high risk of infection because a lot of patients end up getting complications. About 36% get complications. 10 to 16% are because of empyedemas that are actually found. The rest of the complications most likely have to deal with acute kidney injury. And so really we don't think about pleural catheters unless they are going to hospice and it's or they're at high risk of bleeding, or they really, really, really have frequent forward-facing TCPs. And if you're thinking about transplant for a patient and you're thinking about putting in a pleural catheter, usually this is when you want to call up the LTU and ask, hey, like, is this a good idea before we do it? And this slide kind of goes back to the point that patients with hepatic hydrothorax, their outcomes are really bad. And so the management choice is not clear. We recommend TIPS only because this seems to be the least bad option after we do propensity score adjusted analyses, which means that it's still bad, but it's probably the best of all the options available. So these are general conclusions of TIPS. It does have a survival benefit in patients with refractory ascites and variceal bleeding. If you're thinking about TIPS, you should be also considering thinking about transplant evaluation. And usually before TIPS, we get an echo and also a cross-sectional imaging to look at hepatic vasculature. All right, so our patient gets a TIPS. He's now developing worsening ultramental status, new oxygen requirement, and his AKI, which has improved, is now getting worse. Is this ACLF? And we'll cover this in a future lecture. But I think this is the most interesting question, is that this patient is now choice number A. Which patient or patients should you refer for liver transplant evaluation urgently? So our patient in the case with alcohol-associated cirrhosis, now with decompensation after TIPS, 3 months abstinent. B, patient with non-ischemic cardiomyopathy, EF of 20 to 25%, decompensated hep C cirrhosis. C, woman with NASH cirrhosis, BMI 45, frequent admissions for AKI or HE, MELD of 32. D, 75-year-old Hep B cirrhosis, acute liver injury, working full-time and exercising regularly before hospitalization, or E, woman with AIH cirrhosis, now with AKI, CKD, and CRT after variceal bleed. So who should we send for a transplant eval? Who should you call up the LTU for? Anyone? Wintu, do you want to? I know you're in the SFGH pod. Afshin says all of them. And so all of these cases are set up with caveats about the patient if you read it carefully. So the first patient, 3 months abstinent. Second patient has horrible heart failure. Third patient has BMI 45. The fourth patient is 75 years old, and E, which is probably the most straightforward of these cases. But the answer is yes, all of the above. And that's because, I think the indications for transplant are rapidly evolving. We are now transplanting for, at UCSF, we are now transplanting for patients with no abstinence requirements under certain circumstances. We now do heart liver transplants, so the patients with cardiomyopathy are able to get organs as well. And so really, I think this is one of the things that give us a call and we'll sort of suss out the case and figure out if a patient should be evaluated for transplant. And so, we'll get into this in a later lecture during the year, but we're going to talk about, indications for liver transplant evaluation. Typically, you think about acute liver failure, cirrhosis, portal hypertensive complications, and MELD exceptions. And the emphasis is like we want to hear about patients earlier because our patient's cirrhosis, if they get acute unchronic liver failure and has these decompensations, you might end up being in a place where you're past the window of opportunity for transplant, and at that point, it might be too late. And so we ideally want to engage referring gastroenterologists when on their first or second decompensation so that we are able to catch them on their third or maybe final decompensation. All right. So that's all I have. Thank you for answering the questions and answering my questions, and I'll take any additional questions.
Hi, Jin. I have a quick question. Thank you
Yeah.
for your talk. I guess one question I had was for like acute encephalopathy.